My name is Dr. Ta-Wei Su, and I'm a vascular surgeon in Chang-Gung Memorial Hospital, Taiwan. And this year, I was invited to have a talk about how to preserve the internal iliac artery in EVA procedure. According to the literature, up to 30% AAA involved with iliac artery aneurysm. In order to secure the distal sealing, embolization of internal iliac artery is a standard method. However, block the flow of internal iliac artery will lead to some complication and deteriorate patient's quality of life. And by anatomy, internal iliac artery flow supplies three major organs: bladder, rectum, and uterus. And the three main areas: the perineum, inner leg, and buttock. So after embolization, the flow of internal iliac artery is blocked and some complication occurred. For example, 50% patient complain of buttock claudication and 30% complain sexual erectile dysfunction, and up to 9% patient have the colon ischemia. So in the past few years, several doctors proposed the strategy to preserve internal iliac artery, such as the bell bottom technique, travocation technique. And in our department, we use the IBE and sandwich technique widely used in our team. I can say in the case, the blood flow of internal iliac artery is planned to be blocked or embolized in the procedure, the technique to preserve the internal iliac artery should be considered to use. That means this procedure is used to treat most iliac aneurysm. In the preoperative planning, we carefully evaluate the morphology and anatomy of iliac aneurysm and deliberate how to preserve the normal flow. Like other aortic intervention, we have to understand the technique itself and the device we may use. Each technique has its own concept and skill. In preoperative planning, we should think about these key points. The first question is, should we preserve the internal iliac artery flow? And the second, which technique fits the anatomy and morphology of the aneurysm? And the last question is, what is the challenges in the procedure?